Well, good morning. My name is Gabe Kwong, and I'm a postdoc here at MIT in Sangeeta Bhatia's lab, and we live at the Koch Institute not very far from here. So this morning I want to talk to you, share with you our technology which lives in the diagnostic space, and specifically in the area of biomarkers. Now, if one were to step back and look at the global biomarker market, it's actually quite large. It was $13 billion in 2011 and is slated to grow at a very robust rate, such that by 2016 is estimated to be about $26 billion. Now, within this pie, it turns out that applications in diseases that are typically associated with aging, these would be cancer applications, applications associated with cardiovascular diseases, these constitute the largest potential revenue. And especially if one were to focus on cancer, there are going to be about 13 million new cases by 2016, for example. And a lot of these new cases would rise in emerging markets, such as in India, which about 1 million new cases would be slated to arise per year. And so in this particular space, we are very interested in developing cheap and better ways of detecting diseases such as cancer. And so if one were to think about what is actually needed in the biomarker space, here I'm just showing you a very simple cartoon where I'm showing you disease burden on the left-hand, on the axis, y-axis, and showing you over time a cartoon of a healthy patient that would have some disease burden that arises. There will be a therapeutic intervention, and then there potentially could be a recurrence phase. So biomarkers can be used to personalize the entire time course of clinical management of a disease. And so, for example, in cancer, we now have biomarkers that can be used to assess for risk in otherwise healthy individuals. These would be hereditary risks, for example. At the time of diagnosis, there are a number of different companion biomarkers that we can look for, which can predict the patient response to new drugs. And for example, also in the context of monitoring, we have very good biomarkers, fairly good tests, which we can use to monitor recurrent disease in high-risk populations. Now, the challenge, of course, is that despite their importance and potential to personalize medicine, we frankly just don't have enough biomarkers. And this is especially true for early detection and monitoring the efficacy of treatments. And so our technology, we describe it as synthetic biomarkers. And this is just a very quick cartoon of how it works. And what it does is we leverage advances in nanotechnology, okay? And so what synthetic biomarkers are is that we take nanoparticles, and they will be decorated with small protein fragments that are called peptides. And the idea is that we can pull together these nanoparticles to form a single injection, okay? So it's an injectable diagnostic that when administered to patients would then, these nanoparticles would deliver these peptides shown in color to the disease site, where now these peptides would interact with a class of enzymes called proteases. Now, proteases are essentially molecular scissors, and what they do is then they will cleave these small protein fragments off of the nanoparticles, and then these fragments, when they re-enter into the bloodstream, are actually very rapidly concentrated into the urine. And so what we have, again, is an injection of nanoparticles followed by urine analysis to detect disease. And this approach can be quite sensitive because there are two modes in which signal is amplified. So for example, because we are looking at the catalytic ability of proteases to cut these peptides, one copy of a protease could cut thousands of these peptides per unit time. And the second thing that makes our platform unique is that we're not actually looking in the blood. We have 5 liters of blood, and when these peptides go into the bloodstream, they're actually significantly diluted. So this is a major problem, but we're actually looking in the urine, which leverages the fact that our kidneys are able to concentrate these very small fragments into the urine. So these two modes, the ability to look at an amplified signal by these enzymes as well as in the urine, is in stark contrast with the standard model of a blood biomarker where, for example, a tumor cell would be producing a biomarker shown in green at a certain rate that's limited by how quickly a cell can actually make a protein, for example. And once this biomarker is present in the blood, it does not have the ability to amplify its own presence. Okay? And so this two abilities of synthetic biomarkers allows us to start thinking about very sensitive detection and early stage detection of diseases. And so what I'm showing you here is mathematical models showing you the sensitivity of a typical blood biomarker for a certain size tumor. And you can see here in red is our technology that within several hours you can create a fairly amplified signal very quickly in the urine that can supersede the sensitivity of a normal blood biomarker. So does this technology actually work? We have accomplished a number of studies in many different animal models, looking at cancer, for example, looking at liver disease, looking at blood clots localized to the lungs. In all instances, what we find is that the take-home message is, you can see here, that the bladders of these disease-bearing animals are lighting up, okay? And this is evidence that these particles are indeed being degraded and that these signals are concentrated and localized to the urine. And so with help from the Deshpande Center, and specifically with Jeff Arnold, our catalyst, we are refining our technology, and we're initially looking at the prostate cancer market, and it's because the prostate-specific antigen test, or the PSA test, has certain features that need to be improved. And the first is that, the most important one, is that the PSA test currently has a very poor negative predictive value, in the sense that if you have aggressive types of tumors which require treatments, and versus indolent type of cancers which you can just wait, it cannot differentiate the two. And so there is a tremendous burden on a healthcare system, and in fact, the misdiagnosis and overtreatment of PSA or prostate cancer due to PSA positive tests cost our healthcare system about $2.6 billion annually. But this still remains a very important test, and there's a very large market. There are about 42 million men over the age of 50 would be taking these tests per year. This is a market about $3 billion. And furthermore, one of the areas that we think we could potentially improve is if we can be more specific in differentiating aggressive from indolent types of cancers, we can also potentially remove the need for a biopsy for follow-up, which is a sizable $700 million market. And we have evidence now that we believe that this potentially could work, because if you were to look at, ask what are the type of proteases that will be associated with more aggressive types of cancers, it turns out that there are a number of proteases that have been associated with more aggressive types of prostate cancers, shown here on the right-hand side, looking at metastasis of metastatic prostate cancers. And so that's basically where we're proceeding with prostate cancers. Now, there certainly are additional applications. One of them we're interested in is looking at liver metastasis. And of course, the primary cancer rarely ever kills a person. It's metastasis is actually responsible for 90% of all cancer-related deaths. And so metastasis, if we can catch it early on, would most likely lead to improved patient outcomes. The second area that we're also actively pursuing is technological improvements, and that is the idea of developing a companion paper test, okay? This would be the same type of technology that a home pregnancy test employs, that you could buy at the local supermarket. But these tests now, because it's on paper, it's going to be very cheap, about 25 cents per test. It's no bigger than a quarter, and would have the potential now to indicate complex diseases like cancer instead of pregnancy. And so I will stop here, but I do like to acknowledge a fantastic group of team members that we're interacting with. For example, of course, I have to thank Sangeeta, and David Lee. We first started this before we submitted our grant for Deshpande funding, and now Jeff, our catalyst, has been tremendously helpful. We also have collaborators at at MGH, which also helps us streamline some of our ideas, as well as Lauren Foster through the TLO. So thank you, and I hope to talk to you more at our poster session or at the lunch session later on.
Thank you.